Thank you.
All right, so let's do a quick roll call. Dolores Trujillo is present. Vice President Mary Fagan.
Mary Fagan here.
Elizabeth Woods.
Woods present.
Thank you, Mary. Thank you, Betty. Jovita. Looks like Jovita may have problems unmuting. So we'll move on. Susan Naranjo. Susan? Okay, I hear you. Patricia Nguyen.
Win here.
David Lawler.
David Lawler here.
And Vicki Granowitz. Vicki? All right. I believe we still have a quorum. So why don't we go ahead and get started?
Was there only one board member not in attendance? Was it just
Oh,
Vicki?
it's on.
Sir, what was that?
Yes, it's just Vicki.
Okay, and was Jovita able to unmute?
Yes.
Okay.
Jovita's on. Jovita?
Thank you. I got disconnected and so thanks for unmuting me.
Okay, I will also reach out to Vicki.
All right, so why don't we get started?
1 second. Okay. So 7.0 is taken out of order because we do have Julie on and able to present. This is a requested presentation by our board vice president, Dr. Mary Fagan. And so I did get just a little background on Julie Morath, in that she serves as a president CEO of the Hospital Quality Institute, a collaboration of the California Hospital Association and the Regional Hospital Association, supporting over 400 hospitals and health systems in California. Morath has been inaugural recipient of the John Eisenberg Award for Individual Lifetime Achievement in Patient Safety, and was named by Becker Hospital Review as one of the top 50 experts leading patient safety. So at that point, I will open it up to you, Julie. And our board moderator does have your slides and will be able to work with you on the presentation. Thank you.
Thank you, Laura. I have just one update. I have retired from the Hospital Quality Institute, and I am now working as president of the Collaboration for Accountability and Improvement out of the University of Washington in Seattle. But still very much engaged in California and with hospitals. And I would like to thank Mary Fagan for reaching out and inviting me to consider presentation to you, because I think this is so important. The importance of the Board of Nursing for our professional integrity and regulation, and also for the public trust. As you know, there has been declining trust of the public, and our patient and community activists have been very critical. And the focus of today's presentation is really a window in which to take a look at this phenomena. Next slide, please, Mark. So this is Vanderbilt University Medical Center. And it's the lens by which we'll look at the Rhonda DeVaught case. As part of the Lucian Leap Institute, we took a very deep dive into this case and the events at Vanderbilt out of concern for its effect on the and the management of a medical error and series of events that resulted in a tragic death of Carlene Murphy. Now, to us that have been involved in the patient safety movement for decades, saw this as a major turn back of time, where there was a single individual called out as the cause, and there was a lack of organizational accountability and a potential chilling effect on reporting and an erosion of psychological safety. So this psychological safety is a big piece of speaking up rather than silence, and engagement rather than fear. And so we took a very close look at this, and I'd like to start by just walking through a timeline with you. So on November 26th in 2017, nurse Redonda Vaught mistakenly administered IV zirconium to a patient in radiology, Charlene Murphy, who subsequently died. Ms. Vaught reported her error to the treatment team and participated in the investigation. Next slide, please. In 2018, in January, Vanderbilt fired Ms. Vaught and negotiated an out-of-court settlement with the Murphy family, but did not report the error to the state or to federal officials as is required. On January 10th, 2 neurologists completed Mrs. Murphy's death certificate, classifying her death as natural due to a brain bleed. The medical examiner did not investigate the case. Next slide. In October, an anonymous tipster alerted federal and state officials to this event at Vanderbilt. The Tennessee Department of Health did not pursue disciplinary action, stating the case did not constitute a violation of the statutes of the rule, and sent Ms. Vaught a letter saying it did not merit further attention. Centers for Medicaid and Medicare and Medicaid Services, CMS, however, conducted a surprise investigation of Vanderbilt and found a long list of deficiencies which they required Vanderbilt to remedy. Next slide, please. In 2019, Ms. Vaught was indicted for her role in Mrs. Murphy's death and charged with reckless homicide. The indictment seemed to be focused on a single prosecuting attorney with interest in this case. This could be like an 8-year prison sentence. In 2021, on July 23rd, the Tennessee Board of Nursing revoked her license. In 2022, Ms. Vaught was convicted of criminally negligent homicide with this potential prison sentence that I mentioned, up to 8 years, a felony charge. On May 13, the court sentenced Ms. Vaught to 3 years probation and the possibility of having her felony conviction dismissed after that period of time. We think this is a very wise decision made, in that there was accountability assigned to Ms. Vaught for her practice, and there were considerable concerns regarding her practice at this time. However, it did not go to the extent of requiring her to be incarcerated. As you might imagine, nursing protests were far-ranging throughout this period of time. And as you know, nurses are at the intersection of science, technology, and practice, and are often the final touch point of an IV being hung, of medication being administered, of device use, of programming fluids. However, it is very rare that that last point is the cause of harm and death for patients. And this is the point that we were very concerned about, is that this is about systems. And that does not relieve an individual clinician, nurse, physician, other of their accountability to practice, and to practice based on the standards, their training, and their experience, and that which would be validated by individuals of their profession. Next slide, please. So what we did in the Lucian Leape Institute is collaborate with the American Nursing Association, the National League for Nursing, the American Board of Internal Medicine, and others to take a look at a public statement of our concern about this case and what this case may do to those who are on the front lines, doing their best, working in a tremendous complexity, and recognizing that more often than not, they are protectors rather than perpetrators of error. So the NLN came out with a very strong statement that I'm going to review with you if you've not seen it. And that is, nurses advocate for a just culture. And it indicates that nurses have long been proponents of advancing a just culture and the priority of establishing a culture of caring in all healthcare settings, and that criminalizing healthcare errors threatens years of efforts to establish this cultural climate for us to do our best. Next slide, please. Their statement, which is available on their website, was published and widely reflected throughout the nation to look at how nursing views what happened in the Vaught case. Next slide. So what is this just culture that's being referenced? Well, in the delivery of care, processes may fail and mistakes may occur in spite of our best efforts. But we believe it's vital to support a just culture where individuals are held accountable for any misconduct or gross negligence, and that it's in an environment where individuals can report, speak out, and have cultural freedom from blame, and that organizations are accountable to improve processes to promote safe and quality healthcare, which includes the use of human factors, the design and end user collaboration to make sure that's what intended is actually workable in the workplace, and that there's effective peer review and human resource practices that result in disciplinary action, and that civil proceedings may be utilized to promote public safety as well as to provide restitution for harm and errors. Next slide, please. One of the best tools to look at culpability of medical error and harm is one by Reason, James Reason. It's been around for quite a while, and although it isn't perfect, it provides a prospective view for decision making when an individual is in the rubble when things go wrong. And that moves from intention to unauthorized substance, to violations of operating procedures, to review and pass a substitution test in which other like professionals would perform, and to also consider a history of unsafe acts. And what we do when you answer and go through this algorithm is look at three main areas: that there's counseling, there's coaching, and there's discipline. But in each, there is accountability. Next slide, please. So what the organizations that I've referenced are saying is there is a better way to address human error than to blame. And this requires a number of things. The first is astute management. And that means establishing a cultural climate of psychological safety for people to speak up, speak out, and where their voices are heard and respected. That there's close scrutiny and attention to operations. That there's ongoing oversight by both boards, organizational leadership, and professional associations. That there's continuous implementation of ever-evolving safeguards. And this is using human factors sciences, closing gaps between design and technology, rigorous application of failure mode and effect analysis, and reliability testing with the people that are going to be interacting with the technologies and the processes that are put in place. And there's this need for the continual revisit because everything is always changing. And importantly is a confidential, transparent organizational channels that allow all parties involved to come forward voluntarily to honestly report self-mistakes and report their concerns about risks and vulnerabilities that reside in the environment in which they work. So boards of nursing are absolutely essential in advancing these key concepts and practicing consistently with them. And I know the very difficult tension you work with to look at provider individual performance, which is absolutely essential, but also do so in the context of the environment in which they are working. One of the biggest ahas in this whole thing was the individual nurse made some big mistakes, was reassigned to an area she's never worked in before, had a student with her, used a Pyxis machine to retrieve medication, which to be Versed for light sedation, when in fact the alpha order to access the medication only required the first three letters of the drug. So Verconium and Versed both appeared. The signal that it was a dangerous drug was missed. It was retrieved from the Pyxis. It was administered. Best practice has about 5 alpha signals, and Versed always requires the ongoing site of care monitoring by a qualified professional. This was not the case. Nurse Vaught was told that it's not necessary and that she was free to leave the practice environment, which meant there was not a clinical nurse monitoring the state of the patient during this immediate time. So is there accountability for gaps in practice? Absolutely. But there's also gaps in accountability. This nurse was abandoned by the organization. The organization did not step forward and do what the public expects of it, and that is reporting so that learning can occur, to letting us across the country know what findings are so that we're not repeating the tragedy that took place at Vanderbilt, and that our governmental and oversight agencies can be trusted to do their job, which is to come in, investigate, and hear every concern that is expressed. So the three big takeaways are on the next slide, and that is the culture. And leaders both define and shape culture. And that's the culture of stepping up, stepping out, and cultural freedom from blame. So that instead of pointing at individuals, we're looking to continuously learn and improve. The second is accountability. There is no way around this. Accountability and transparency are hand in glove. And at each level in the organization, at the site of care, at the management of care, the oversight of care, and in our public organizations, that accountability has got to be visible, stand strong, and be unassailable. And the final is justice. And that is having clear and prospective algorithms and frameworks in which to judge and make decisions about individuals and organizations when harm happens. So that is kind of my overview of the case and what I think the implications are. And I need to acknowledge the wisdom of the sentencing judge. This could have gone in a completely different direction. And she provided a sentence that required and spoke to accountability, and at the same time did not criminalize to the extent of a prison sentence for the individual nurse involved. Now, we don't know what happened with Vanderbilt because that has been completely silent, but there are activists across the nation that are demanding accountability from the organization and its top leadership, as well as from the public health department in Tennessee and CMS federally for their requirements for oversight and protection. So if time permits, I'd be happy to field any questions or comments that you might have.
That was a wonderful presentation and timeline. Thank you, Julie. Any questions or comments from the board?
Julia, I have a question, and thank you so much for this presentation, and just so I can acknowledge your expertise in this area. But is there any specific role that you would see for a board of nursing that the board could take in order to either put some policies in place or set some regulation in place or something that would perhaps help guide decision-making in terms of, criminalization of medical error or decriminalization?
Mary, the public, we're sort of bicultural. There are many factions that still want heads to roll when things go wrong. But I think that the board could be very influential in reducing the drive toward criminalization in the state of California. I think that we're a fractal and in large part reflect what is possible in healthcare in this country. And I would like to see that as a constant kind of drumbeat and a philosophy of the board around the notion of psychological safety, learning versus blame, and second chances to those who have been involved in harm, but it was not through intent. and some of the decisions you have to make about practice and some of the policies that you put forward, I think are going to be essential. One is around learning versus blame, remediation versus criminalization, reasonable. And also the notion of transparency, that the public has a right to know. And I think the Board of Nursing in California are really, you're exemplars in being transparent about your decision making. And we need to encourage the organizations in which nurses practice, in the environments in which they practice, to model that same kind of transparency about performance and that same kind of commitment to continually improve. That would be my list.
Thank you.
I have a question. When you talked about just culture
Mhm.
as a concept, it sounds a lot like it's based in the restorative practices ideas used in other industries, and I'm wondering, is that something that can be maintained through policy, or is this just an idea for nurses to consider?
I think it can be driven through policy. And thank you, David, for your question. I was co-author on a psychological safety tip sheet for the Collaborative for Accountability and Improvement. It's free, it's downloadable, and it takes you through what the components are for developing a psychologically safe environment and for the roles and responsibilities of leaders to lead those kinds of environments. So I'd invite you to take a peek at that. There are a couple things brewing. I'm a member of a 6-person advisory group to the President of the United States Council on Technology and Science, PCAST. And we have been working feverishly over the last 4 months to produce recommendations for the White House to consider moving toward legislation or standards. And there are a couple of those that are relevant to your question. The first is that every organization would provide access for any patient harmed or put in harm's way for a process of communication, transparency, and reconciliation. So that would be like a condition of participation. So that is coming about, and I think it could happen, you know, in influence in the state. And then the other is around the notion of the culture and the accountability of leaders, from boards to those in operations and executive positions, and that the degree of preparation and engagement and transparency in those roles are held most high and will be of much greater emphasis. The other is requiring the use of usability testing and human factor science whenever new technology is being introduced into a clinical setting, to support nurses and other caregivers who then have to use it, who may not have had the opportunity to kick the tires and really understand how it's going to work in the real world. So those are 3 big things that are in draft form that we hope to see. The other is, and I think the Board of Nursing can be very influential, is we are under a tsunami of measures, right? And what 30 to 40% of nursing time is spent finding fugitive data, documenting, needing to respond to many different nuances in how different organizations want information reported. And so there is a call to take the top concerns for harm, have very specific, well-defined measures, and focus on those with the alignment of the practices known to mitigate harm, so that you have areas of focus, priorities, appropriate measures, and then best practices or better practices, because best practices, what a point in time, that align, so that we've got this continuum of how to get better at getting better. And nurses carry so much of this. And I think that that whole question of measurement is also something that fits with policy and legislation.
I would add, nurses, like you just said, bear so much of that burden, but the factors that can mitigate harm come from the institution. And so I think part of this, the system changes, if you're talking about psychological safety, would hold the hospital accountable, not just the nurse. He or she is not an independent contractor isolated from the building they're working in necessarily. So
No.
like you said here with this hospital that the nurse was in and the harm that took place at Vanderbilt, I don't know, maybe Reza can answer this, how California is set up for our medical center to be considered as one of the mitigating factors in any medical error.
You know, David, nurses practice in a context, and the context is the environment. And the
Yeah.
environment and the climate of that environment is defined and created through its leaders and how it listens to, works with, and respects those closest to the work. So you're spot on.
So David, I'll jump in before Reza does and just kind of give a little background real quick. So California Department of Public Health oversees the healthcare facilities. The Board of Registered Nursing does not. The Board of Registered Nursing oversees the licensees, so the individual RNs. And so we have to work collaboratively together. One of the great things that our board has are disciplinary guidelines. We have an intervention program. And our board, in the mission of public protection, is about rehabilitation, is about getting the nurse back on their feet, supporting them through their probation, having them do remediation with classes, etc. And really have been a leader in that for quite a few years. And I'm sure as you participated in some of the closed sessions over the time, you do see that a lot of our nurses regain licensure and they complete that process successfully. We report that out in our education and intervention committees, and here at the board too, just really on all of those processes. And it's really amazing to be a part of that. The other thing to take into consideration is the competency and that of the nurse, and that is not established by the Board of Registered Nursing. We establish the scope of practice. That competency is done on a healthcare facility-wide level because they have the person in front of them, and they work with the provider, with the administration of the healthcare facility and the individual RNs to ensure that they're competent. They develop standardized procedures, which we have the guidelines for, but they actually do the standardized procedure development where they talk about what makes them competent, what kind of testing, what is the routine evaluation, what involvement do other people have in it? And that's established by that facility because that has to be carried out by the facility. So we do work in partnership with it, but it doesn't necessarily lie solely within the BRN. And so that's kind of a huge thing that a lot of people don't understand, is that collaboration that we have to have with CMS, with CDPH, with the BRN, because the BRN has the license component of it, and all of the other areas have the insurance processes and health and safety processes and other kind of regulatory laws around labor and around competency, et cetera. So it's really just a group consideration there that we can all work together in. In my prior job, my prior lifetime, it feels like, prior to becoming the EO, I worked in a very large healthcare system that we all did just culture. That was everything. Every leader had to go through that and be trained in that. And it was employed at a very large healthcare organization level, and it was effective. It was really great to be a part of that team and really see how those processes worked, knowing that the understood kind of aspect of it is that everybody goes to work to do a great job. They go to work to serve and do better and help, and that's really where that is. And when you vary from that, you have to look at a systems level. You know, in part of our strategic plan, we actually talked about FMEA and root cause analysis and such, and that was also part of our SLAY that we report out on as well through here. So it has been brought into the BRN, and that's something that we're looking at. And our enforcement department, when this came out, actually talked about just culture and brought that up in management meetings and discussed that. And then I had the wonderful opportunity to meet with the EOs throughout the nation, and specifically the EO, the Board of Registered Nursing in Tennessee, where this did occur, and kind of talk about what was their role in this and how did they work with that and take those as opportunities to really learn and discuss and share and work with that. So really, really great stuff coming out of this from all levels to really bring this to the forefront and have it to be communicated. If you still wanted Reza to chime in, if you think that that's still appropriate, he absolutely can. I don't know if you want to just open that same question up to him, or if you had anything specific for him to address.
That absolutely puts it in context for me. It just sounds like California as a state seems to be I don't want to say ahead of the game, but leading the way, and could be used as the model. And I assume we're being used as the model, or should be, for what you see happening nationally with your work in Washington, D.C.
Yes. We're an awesome state. I really believe in California. And Loretta, I think you articulated it very clearly, that one of the things we find in safety is there are so many organizations that all have a part of it. And very often what happens is there isn't the spirit of collaboration and alignment that you described, that you practice. And so that's the other thing, is the openness and some semi-permeability of boundaries in order to be clear, aligned, and strategic about the work. This is a big ship to guide. Thanks for everything you're doing.
Thank you. Takes a team. We've got a great team.
All right, any other questions or comments from the board? If not, oh, go ahead.
Sorry, I don't know if anybody else jumped in, but I really wanted to also just kind of wrap this up real quick with one more thing. Is when we were looking at implementing the regulation language update for 1450 and 1456 for continuing education providers, and what kind of classes are available, California Hospital Association left a comment that said to define experimental procedures, and it says, under the definition contained in 1456D, a drug used as experimental if the US FDA approved the drug and it says off-label use, and it kind of talks about that and really kind of talked about, other options. And so as the board, we took that feedback into consideration, and we did allow for off-label usage to be done as continuing education. We also included biological products, devices. That was one of the big things that was on the recommendation here from Julie, to really have a consideration for continuing education unit hours. And so when California Hospital Association brought that forward, we took that into consideration and changed the language and updated the regulatory language to make sure that it included that as part of it, so that that training received at the direct patient care level can be supported with continuing education units. And so that was one of the other show of collaboration where through the comment period in the rulemaking process through the Office of Administrative Law, we got really great feedback. We took it into consideration, changed language, put it back out to a comment period, and that was just accepted and is now part of our regulations as of, I believe, October of this year, where that is supported. And so right in line with those recommendations, Julie, and before I'd even heard that, that was something that California Hospital Association put out, and the board listened in collaboration and made change to our regulations to reflect that. So just wanted to share that good news.
Just like you have for renewal of licensures, certain requirements in education that include infection control, right? There's no reason we couldn't have other requirements that look at safety science.
Yeah.
And
that,
most of us never learned that in our training.
yeah.
And it's imperative today.
It really is. And that's why the board preemptively went ahead, took that information and updated it to reflect that, to make sure that it was clearly codified within our regulations. So thank you for that.
All right. Thank you, Julie.
My pleasure. Thank you for having me.
If there's any other questions or comments from the board, otherwise we will go to public comments. Seeing that there is no other questions or comments, Beer and moderator, please open it up for public comments.
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give reminders as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Scott RN would like to make a comment. 1 second, please.
Hello, can you hear me?
Yes, sir. Go ahead.
Hello, my name is Scott Shelp. I'm a registered nurse, and I have the Nurse Scott channel on YouTube. When the verdict of the RaDonda case was announced, I posted a video disagreeing with the nurses who were protesting and defending RaDonda. The video was picked up in an NPR Kaiser Health News article, and I was reluctantly brought into the larger discussion of the case. I was even interviewed by the NBC affiliate in Nashville. To be clear, I never supported criminally charging her. I only wanted to say that the charges were not unfounded. In that, I found myself at odds with many of my colleagues. I'm commenting to express what I know by the comments left on my videos is an opinion that many nurses share but have been drowned out by the "I am RaDonda" crowd. While in many cases like this, there is blame to share. There might be significant systemic problems that contribute to the error. However, this simply was not the case here. RaDonda alone was responsible for her error. As a general principle, we nurses must stand together, but we must also enforce our standards. In this case, we cannot defend the indefensible. Not to say criminal charges were necessarily appropriate. There's so much to say here, but the most important point I'd like to make is that it serves no one to continue to shout that this case, the charging and the verdict, will make nurses less willing to report errors, will scare potential nurses from entering our profession, and will cause many nurses to quit the bedside. Sadly, the ANA was part of this. I believe this should be an opportunity to rededicate ourselves to safe care, to reassure the public that the trust they have in us is not misplaced, and to communicate to future nurses that although the job comes with great responsibility, and perhaps because of that responsibility, that it still can be an incredibly rewarding career choice. Thank you.
Thank you for your comment. Laura House would like to make a comment. 1 second, please.
Thank you, moderator.
Thank you.
Two things. One, I have had the pleasure, by the way, of working with Mr. Shelp in a previous lifetime, and I thank you for your support of nursing, Scott. But in addition, I would like to indicate that when it comes to just culture, I had the privilege of being a middle manager with Cedars-Sinai in Los Angeles during the Dennis Quaid Heparin incident. We looked at ourselves with a fine-tooth comb, in addition to having organizational colonoscopy from every regulatory agency known to man. And we came through it learning more about ourselves and more about the commitment that we had to our patients and to all members of the staff. We learned how, as physicians, nurses, pharmacists, technicians, all of us working together could provide for a safer environment. But we also recognized that until the time comes when human beings are not involved, there may always be an inadvertent error. And if we can support each other during those times, we can psychologically support, fiscally support, and demonstrate true organizational accountability. Thank you, board.
Thank you for your comment. Alyssa Brown, 1 second, please. Alyssa Brown. Yeah, we'll come back. Kathy Hughes.
Registered nurse and the executive director of the Nurse Alliance of SEIU California. While we recognize the importance of nurses taking responsibility for medication errors and other errors in practice, we do believe that criminalization of med errors is extremely problematic, especially when you're looking at inadvertent med errors. We find that our employers oftentimes use the filing of BRN complaints as a form of retaliation, and we could see where this would become a very slippery slope when we find our employers filing additional complaints or trying to criminalize med errors. We appreciate the BRN's vigorous investigation process during this complaint process, because we know a lot of those nurses are found that those BRN complaints are unfounded and they're able to return to practice. We do believe that there is organization accountability, and we find that most times the errors can stem from some kind of system error or problem with that within the system. So we appreciate this presentation. We really appreciate this presentation, because we do have nurses that speak about being afraid of being human and making a med error that they might end up having to serve time for, and what a problem that could be to our profession and to our patients that we provide the care for. We do think that we need to address system errors and look at remediation and education. Thank you very much.
Thank you for your comment. Sangdao Funkslinkson would like to make a comment. 1 second, please.
Hi, I am Sang Dao. I have been a registered nurse for since 2004. Been doing really great and has helped a lot and mentor a lot of new grads and went from level 1 to level 4 and helped a lot of nurses to become leaders and upgrade their self to level 4 and practice. So I finally, I felt like at a level where I really need to participate more, advocate more, and I decided to go into advanced practice. So I did, and I got, finally, I had sleep on a decision for a long time whether I wanted to get out of that comfort zone and advance and further represent nursing as a profession. I did take a new role, and never once in my life did I ever felt, as a nursing, I always advocate, want to mentor, to lead, but I'm sorry, I got a little emotional, but what all you have described today is like, I see you're describing my situation. And
Thank you for your, oh, are you there? Go ahead.
yeah, and I really appreciate your discussion because what you're saying, it's really out there, and I'm waiting patiently. I'm psychologically affected by it, so I wanted to make a difference. I wanted to make a change. I said to myself, this is not going to happen to any other new grads or a new novice nurse practitioner or out there who wants to further and they're not getting supported. And it's out there. It's an institution. It's it's a system, and I'm really grateful for this opportunity to allow for public participation because I'm here because I really want to know what I can do on my part to help at a higher level so that I can prevent this from happening to any other new nurses that wants to advance and participate and advocate. Thank you. So I really appreciate this session and I look forward to participate some more.
Thank you for your comment. Alyssa Brown.
Looks like she made a comment that she could not unmute.
I'm
No, she's
unmuted
unmuted.
now.
She's unmuted.
Thank you very much. Yeah, it wouldn't unmute for a while. I just want to thank you so much for this presentation, Julie, and for the responses that we've heard. Your overview has been wonderful. I think our BRN has one of the best programs for helping nurses in getting back to work and recovering, so I'm always touting that. I'm a psych mental health clinical nurse specialist. I'm also involved in ethics, so this issue has come forward in all the ethics committees I'm on, and the scare and the fear that people still have of reporting. We had worked in a large system. We had just gotten policies out about reporting without fear, and now they're worried that not just nurses, but no one will report it. So, I really believe we have to have policy to provide that just culture and a safe place for people to be and to talk. And that's, not saying that we won't look at everything, but we look at the individual, we look at the systems, as people have talked about, and look at the total process. And you don't learn very much if you just start blaming people, but if you start trying to get to what happened and how we can make things better and not so it doesn't happen again, that will help. So thank you so much.
Thank you for your comment. Chaisha Watts would like to make a comment.
It's for agenda items 6.1 and 7.3. Can I only do one or to do both of them at the same time?
We haven't taken 7.3, so you are not able to speak on that. 6.1 is what is being presented right now, and so this is the public comment period for that. Thank you.
I'm sorry, Lori, I think you said 6.1. This is 7.1, the presentation on criminalization. So for the commenter, yes, please try to keep your comments to the agenda item currently at hand. There will be opportunity for comment on each agenda item as they come up.
Okay, if this is 7.3, then I don't have any comments right now. Thank you.
It's 7.1.
Thank you for that catch, Reza.
Board President Trujillo, there are no other public requests for comment. Would you like me to close this window?
Yes, thank you.
And that was information only, Board President Trujillo, so no vote would be needed. There is a request. We do have Samantha Gambles-Farr. She is the chair of the Nurse Practice Advisory Committee. Can you elevate her board moderator? And then the request, Board President, is to take 7.2.1, sorry, out of order. And we're going to take that presentation, that update from the Nurse Practice Advisory Committee in advance of moving to 6.1. As the agenda reflects, 6.1 is the consideration of public comments, discussion, and possible adoption of proposed regulatory text. And that is for the implementation of AB 890. And the Nurse Practitioner Advisory Committee is in the implementation of AB 890. All items have to go through them first before they can come to the board. And so it would be beneficial for us to take 7.2.1 only out of sequence right before taking 6.1. So if you agree with that, Board President, we'd like to reorder.
I do. Thank you, Lori.
Thank you. And it looks like Samantha is elevated. Are you able to unmute, Sam? Samantha,
I am.
sorry.
Can everyone hear me?
Awesome. So if you can do a report out on the Nurse Practitioner Advisory Committee that was held on November 1st.
Thank you, E.O. Melby. And thank you, President Trujillo and Elizabeth Woods, Chair of the Nursing Practice section. I wanted to come on and provide you guys with the report from the Impact Committee meeting as previously stated by E.O. Melby. The first thing that we took care of as far as agenda items was we, of course, approved our minutes from August 9th, 2022 with some corrections and spellings of participants' names and stakeholders' names. The second thing we did was that we had a report from Executive Officer E.O. Melby. And as she previously stated, one of the things that she discussed was the Sunset Bill, and one of the things specifically was the removal of billing ceilings for minimum and maximum amounts of fees. This is important to Impact Committee as it relates to eventual auditing and evaluation as to the fees that will be incurred or reduced as an effect of AB 890. In addition to that, there was discussion as it relates to keeping furnishing numbers. However, that there would not be an additional fee occurred to that moving forward. It would be part of the nursing, the nurse practitioner having certification through the state. And those were the two primary items that E.O. Melby provided for us during her executive officer update. And I don't think that I missed anything. Did I, E.O. Melby? Okay, thank you. The next thing we talked about was the election of the chair and the vice chair. I'm happy to say that my colleagues felt that I was doing a good enough job and decided to ask me to continue on in my role as chair of the Impact Committee, and I accepted, and that was voted on. As well as Dr. Edward Ray will remain on as vice chair of the Impact Committee moving forward. The terms of our service continue to be 1 year. And so for the next year, we will continue on in our roles as chair and vice chair. So we thank our additional board our committee members for placing us forward for that. The primary bulk of our meeting was agenda items 7 and 8. Agenda item 7 was discussion and presentation of the Department of Consumer Affairs Office of Professional Examination Services, or OPES report. And that was provided by Dr. Heidi Linser. And in conjunction with all the hard work from Tracy Montez. We really do appreciate them coming and giving us that report. And there were three primary items that were discussed during our meeting. The first being that there was no additional testing required for nurse practitioner as a recommendation. They felt that the current certifications, national certifications in place did not yield any additional need for us to have additional tests here in the state of California in order to transition to practice in as an NP 103 or NP 104. The second thing that was briefly brought up but not discussed in great length was the specialized CE coursework. As it relates to that, there was not hardly any discussion about that other than it was mentioned from either anybody on the committee nor anyone as a stakeholder or public comment. The last and the most discussed item was the transition to practice and mentorship recommendation from OPES. After speaking to physicians, and I think specifically, I don't know if it was a physician group or if it was individual physicians, I can't recall at this time. Their recommendation to have some type of finalized or clearly defined transition to practice and mentorship as it relates to NPs, transitioning from to 103 and 104. Committee members did have specific questions and comments as it related to why only physician colleagues were asked this specific question as it relates to transition to practice. In addition, there was a public comment from one of our I'm trying to think of one of the specialization health, excuse me, I'm sorry. One of the participants that participated in their meetings with nurse practitioners as content expert providers stated that she was not asked about any transition to practice. And so there was some discussion as to why. There was a specific question from Dr. Maxwell as to why nurse practitioners were not asked that specific question. In addition to the transition to practice, there was a question from one of our committee members as to potentially creating a second subcommittee as it related to additional discussion about transition to practice. However, when we moved forward and understanding that the regulatory language was ending its 45-day period of public comment from September 16th to that date, November 1st, 2022. The committee did not feel the need to give additional input as it related to the transition to practice, knowing that there would be additional time to look at the comments that we received in those 45 days. And then if additional regulatory language or change of language was needed, that we would have an opportunity and our stakeholders would continue to have an opportunity for input. And so that was the primary gist of the OPES report. EO Melby, am I missing anything as it relates to discussion?
I don't think so. I do want to make just a couple clarifications, just really quick. On the EO report, you had mentioned fee floors and ceilings. We did not address the ceilings. Those stayed. It's just we removed the fee floors. We don't want the ability to increase our fees past where they're at. We don't need that. We need to look at bringing them down. So the fee floors on that one. In regards to the OPES report that is coming up to our board members at a future agenda item, separate from the regulatory comment period that closed, that's going to be discussed in 6.1. Those recommendations from OPES will be brought back through the Nurse Practitioner Advisory Committee. We did take their recommendations on forming committees for them to work on that, and they will work that process through NPAC with any updated regulatory language for a separate regulatory package in the future. And so that just is an update on how OPS report will be managed. As far as the public comment period, that really is the main reason to pull you up ahead of all of the rest, is because the next agenda item is on the public comments received. You will see in there that there is some reference to what Samantha has shared with a separate regulatory package for OPES and any potential new regulatory packages taken outside of this current regulatory package. So the main things to for the board to take into consideration from Samantha's report out is that the NPAC made the motion to accept the no exam recommendation from OPES as part of the consideration moving forward. And they did not make a motion on the public comments, as she said that she knew that there would be further discussion here in this board meeting to consider those public comments. They did get a chance to review the public comments received up until that date, 11/1, and public comment period did end 11/1 at 5 p.m. All of those have been included in the package and are here for you guys to look at when we move to agenda item 6.1. And so that's really it. Samantha, if you want to stay on, if our board members have any questions or comments around NPAC specific meeting from 11/1, I'd love to have you here and available. And then once this is wrapped up, we will take this out to public comment on the report out of the Nurse Practitioner Advisory Committee, just to make sure that it is not a public comment period for the comment sections that will be discussed in 6.1 and not a comment period for the OPES report. So it is just specifically a public comment time period that is regarding anything that Samantha, that you needed to clarify with Samantha, or maybe say that that was agreement with what you understood, or an agreement or a disagreement with what you understood, that took place at the November 1st NPAC meeting. So I know it's slightly confusing, but I wanted to make sure that that was out there.
Thank you, EO Melby. I did have just one more portion to discuss, which was our agenda item 8 there, where we talked about the public comments raised on the subcategories of the scope of practice for nurse practitioners. There was one specific public comment as it relates to NPs with elective cosmetic procedures. There was also a comment as it relates to the notification from nurse practitioners as NP 103 and NP 104. In statute, AB 890 states that the nurse practitioner must inform the patients. This particular stakeholder felt that a written disclosure would be best needed and best practice as it relates to disclosure. And then the final information had, or the final statement was regarding the Spanish terminology for nurse practitioners. However, that is already in statute in AB 890, and moving forward, that would be the language that we would have to use as it is in statute. And that concludes my report now. Thank you so much.
Thank you, Sam. And all of those comments were included in the comment section that we're going to discuss in the next agenda item as well. Thank you.
This is Betty. Samantha, I have a question, clarification question. When you had talked about the nurse practitioner not having any additional testing that was needed, then you mentioned certification. If you had certification, nurse practitioners in California do not need certification from a national body. So I'm wondering what you mean by that when you talk about certification. Do you believe that the nurse practitioners in California should be nationally certified? Because we don't have that requirement right now.
Betty, for clarification, the national certification is required for the nurse practitioner to advance to a 103 or a 104 NP for their independent practice. So it is not a national certification that is required for licensure in California. That NP certification in California for licensure can be done without a national certification. The national certification that Samantha was referring to was the requirement that is in statute that says any NP that wants to advance to that more independent practice must be nationally certified. And that national certification exam is actually what is being used to ensure that there's no additional testing done for independent practice, that actually covers it. And that will, again, further be explained when we get to the agenda item that discusses about OPES.
Thank you for that clarification.
Thank you, E.O. Melby. Any additional questions?
I would just like to make a comment. And I would just like to say congratulations to you, Samantha, and to your vice chair for your continued leadership on this committee. It's appreciated.
Thank you so much. Thank you so much, President Trio. It has been a exciting, daunting, rewarding role to be serving in. It has not been without its challenges, however, but we are really working towards improving the health of our fellow Californians and utilizing nurse practitioners in that force to move forward. And we really want to make sure that we're staying true to the spirit of the bill and not putting additional barriers in place while being concerned with the safety of our fellow members of California. So thank you. We really appreciate that.
You're welcome. Thank you again. Any other questions or comments from the board? Seeing that there are no further questions or comments from the board, BRN moderator, can you open it up for public comment, please?
BRN moderator, again, while you're opening up for public comment, I just want to give a reminder that we will be going into agenda item 6.1 for anybody that wants to have public comment and discuss any of the comments that have been sent out on the AB 890 regulatory package. And we ask that you save them for that agenda item. It is the next agenda item that we will be hearing. Additionally, if there is anything specific for the occupational analysis that was performed for the Office of Professional Examination Services, we ask that you hold off on that public comment for agenda item 7.3. This public comment period should only be in regards to correcting or coming in support of what the chair of the Nurse Practitioner Advisory Committee just reported out that took place on November 1st in the Nurse Practitioner Advisory Committee. Hopefully that was clear. Thank you.
Thank you. We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for comment. I've activated the question and answer feature. Members of the public can indicate that they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Kenny Chen would like to make a comment. 1 second, please. Go ahead, Kenny. It's #6 or *6 on your cell phone. Okay, I'll come back to you. Dr. Cynthia Yovanov would like to make this comment. 1 second, please.
For that update on the NPAC from our chair. I really appreciate it. But I just have a point of clarification, and this might be mostly directed to Loretta Melby. You did mention something, but it was kind of happening so fast that I may have not caught it all. So I just needed a clarification. In the last NPAC meeting, there was a public member who mentioned maybe consideration for like a subcommittee in regards to some of the recommendations from OPES. And you mentioned that there was possible consideration for further mentoring in an additional regulatory package or separate. I just needed a clarification on that. Maybe I heard that right. Thank you.
Yes, absolutely. Any regulation can be updated at any point through a regulatory package. Our regulations as well as statutes are able to go through changes as long as it goes through the process that is outlined by the Office of Administrative Law. So in next year, in 5 years, in 10 years, if any regulatory
Okay.
needs to occur, then it can be updated. Additionally, if there's any new statute that is put forward that conflicts,
I'm so sorry.
or
Oh, you know what?
then we can go ahead and do that as well.
Okay, perfect. Thank you.
You're welcome.
Thank you very much.
Thank you. Thank you. Kenny Chen. Kenny Chen, go ahead. Let me see. I think he was unmuted, but let's see if he wants to try again. 1 second here.
Oh, hi. Hi, my name is Kenny Chen. I'm a nurse practitioner with Los Angeles County, and I work here in South Central Los Angeles. And I'm a proud member of SEIU, and I just really wanted to urge the board to continue the current regulations that we have proposed. I also would like to thank the board for all the work that has been done to in implementing this bill. You know, here in South Central LA, nurse practitioners like me, multilingual, we really expand access to an area that has been a real dearth of medical providers. So we look forward to seeing this bill be pushed through and implemented to increase access. Thank you so much.
Thank you.
Thank
And just
you.
for board members, that doesn't necessarily go with this update, but it does, but that also could be taken into consideration when we get to agenda item 6.1. Thank you.
Thank you. Margaret Johnston would like to make a comment. 1 second, please.
So just a reiteration that if you're going to make comment about the regulatory package for AB 890, that is going to be agenda item 6.1. We are not on that agenda item yet. If you are going to make comment on OPES, the Office of Professional Examination Services, that is agenda
28
item
years.
7.3.
Yes, this is on the NP issue. I work with DHS and I also am a member of SIU. I think our objective should be to diminish barriers rather than erect them when we talk about access to care. And the board has thoroughly gone through the language of this proposition, and the legislature has done an extensive analysis. Only minor changes need to be made in the first section that's under discussion. Thank you.
Thank you. And just for public commenters, that would have been more in alignment with 6.1. So board members, please take that into consideration when we open up for 6.1.
Dr. Stephanie Dittmer would like to make a comment. 1 second, please.
Good afternoon. Thank you. I wanted to voice my concern about the process of the NPAC committee, how the different hearings over the course of time did not really include a full community level of engagement across the multiple marginalized community members that we have in our state of California. And I also wanted to voice my concern that the process of creating outside of standardized procedures, clinical practice in the state of California should have the standard of care of medical care. And I did not feel that the physicians in the process of creating this new system were adequately consulted and advised in this process. I also felt that many times the clinical care and the concern for consumer protection in the state of California did not really give adequate voice to those concerns.
Thank you for your comment. Board President Trujillo, there are no other public requests for comments. Would you like me to close this window?
Yes, please. Thank you.
Okay, and we could go back into the normal kind of agenda item. We're at 6.1.
So item 6.1, consideration of public comments, discussion, and possible adoption of proposed regulatory text to amend CCR Title 16, Section 1480, 1481, 1482.3, 1482.4, and 1487. Categories and scope of practice, nurse practitioners.
Thank you. So just a quick introduction. AB 890 is kind of the discussion on the agenda today right now. And that was put into effect in September 2020 when it was signed in and brought in. And the goal was having everything be implemented by January 1, 2023. With that, there was the forming of a advisory committee, which was the Nurse Practitioner Advisory Committee that Samantha Gambles-Farr that just presented is a member of and the chair of. And through that, there were several subcommittees that were formed. One subcommittee was specific on the transition of practice. Another subcommittee was specific on the 103 NP, or the NP that can work without standardized procedures in group settings. And the third subcommittee was formed for the 104 NP, and that is the nurse practitioner that works without standardized procedure, but is not limited to working within a group setting, but can have a independent practice within their national certification. So based on that, we held several stakeholder meetings. Those were all held in a virtual manner as to allow for access throughout the state. They were very well attended. We did report outs on a quarterly basis to the medical boards that they were aware of everything as it was moving along, and we kept our website updated, met with several stakeholders throughout this process with DCA as well as Regulatory Council and BRN Council and myself present in multiple meetings and stakeholders. And the regulatory language, as you guys are aware, has been updated a couple times by coming back in front of the board based on recommendations from either advisory committees or stakeholders over the last few years, and was presented as a final package in May of 2022 this year. During that process, it did go out to a 45-day comment period. It did end at 5 o'clock on November 1st. We did, as required by law, put those comments in front of the Nurse Practitioner Advisory Committee, and they, as you heard, reported out by Samantha, the chair of that committee. They did not have any specific recommendations that they wanted to have incorporated into that. And so at that point, I'm going to open it up to Heather Hoganson. She is our regulatory attorney that we work with at DCA. She's going to give a quick kind of review of what the regulatory process is and what this comment period is and what happens after this. And then we are all here for questions and answers. I'm hoping that you guys are able to review the questions and ask some good questions that we can provide clarification on if needed, so that this package can move forward and be ready for our 103 NPs to progress to a more independent practice as of January of 2023. Thank you.
And good afternoon. Heather Klein Hoganson, your regulatory counsel here, with a quick update on the progress so far. As EO Milby mentioned, in response to AB 890, you reviewed a draft of the categories and scope of practice of the nurse practitioner regulations in November 2021. There was some discussion, if you recall, and then you approved a revised draft in May of 2022. Those regulations and the associated documents that go with any proposed regulatory package were then reviewed and approved by the Director of the Department of Consumer Affairs and then by the Secretary of the Business Consumer Services and Housing Agency for submission to notice to the Office of Administrative Law, OAL. Once OAL published this text, as EO Milby mentioned, September 16th, 2022, a 45-day public comment period began. A little over 50 comments were received by the close of the comment period on November 1st. Those comments are all in the materials, and hopefully you've had a chance to go through them. You will notice they have been redacted slightly to keep some confidentiality of personal names, of phone numbers, of things like that. Your role today is to review all those comments, which staff has summarized in the second document, and then determine if staff's proposed responses are appropriate or if edits or changes need to be made, either to the responses or to the text itself. So if no changes to the proposed regulatory text are required and you adopt the text as noticed, then staff will prepare the final package for final review by the Director of Department of Consumer Affairs and by the Secretary of the Business Consumer Services and Housing Agency. Once both DCA and agency have approved the final package, it would then be submitted to the Office of Administrative Law. OAL statutorily has 30 working days to review a regulatory package. Now, we would request that the package be expedited and effective once OAL approves it. But OAL regularly has additional changes which may require additional comment periods, etc., as you have seen in the past. So we are on a very tight timeline if we're looking for implementation in alignment with the statutory timeline. Now, if you do want to make any substantive changes to the text, we would need to hold a 15-day modified text comment period. And then any relevant adverse comments would need to be brought back to a subsequent board meeting for your consideration before staff could go ahead and prepare that final package in that process that I've just described to you. So those are your two options today, is you're reviewing the comments. You're either deciding that the comment responses need to have some edits made to them, or you could suggest that some text be changed, but that will definitely delay our implementation. And as you can see from the comments that we've received, there's definitely at least a third of the comments seem to be in support of moving these as expeditiously and quickly as possible, and so that additional thoughts, ideas could be handled in a follow-up regulatory package. And that's definitely something that we can get to work on for new ideas, for other areas that haven't really been dealt with yet. And then any non-substantive or technical changes in the motion, you could delegate to EO Milby that ability to make those technical and non-substantive changes as it goes through the final process and with OAL. So, and I'm available for any questions you might have.
Any questions or comments from the board?
One other comment I would like to point out, whenever the board says the board incorporates by reference response to comment such and such above, it's a duplicative comment or a similar topic. And so you will see that multiple times throughout the packet here. And so you can see that even though there were multiple comments received, as Heather pointed out, about a third were in support, about a third are duplicative, and about a third are comments that were received here. And you can see how the board responded, and we're open to any feedback.
Any questions or comments from the board? Seeing that there's no questions or comments. Oh, go ahead.
Yeah, I'll just, so this is not my area of expertise, obviously. And, you know, I did kind of quickly go through the comments. And I guess the only thing I would ask about were, and this might be to staff or might be to the chair, but was there any, was there any comment that really jumped out at you that, was kind of particularly controversial? I didn't see anything in just, kind of my quick read through that.
Sorry, yes. I think there was a lot of concern from the medical professionals on there that nurse practitioners may have a more expanded scope of practice than what they currently have now. And one of the big things that I really wanted to point out that I did when I had several stakeholder meetings is the scope of practice was not necessarily updated or changed much with the passing of AB 890. What was updated was a supervision requirement. And so it's not like the nurse practitioner is now going to have carte blanche freedom to go out and perform surgery. That has never been a nurse practitioner scope of practice. They cannot perform surgery. And that is actually stated in a different statute that we have as part of our Nurse Practice Act. And so that was not granted authority through the passing of AB 890, that nurse practitioners can now go and do surgery. So I think a lot of it comes down to is there is great concern that these nurse practitioners will now have this expanded scope of practice that would further go into the realm of medicine, and it does not. And so I think that's one of the big clarifications that we need to make sure that when we're doing messaging that we address. And so I did reach out to Department of Consumer Affairs. We will be working on putting out a news release out to all of the nurse practitioner licensees. It will also go out to the medical board and the osteopathy board and have that sent out by them to really kind of clarify, once this regulatory package is finalized and ready to be implemented, really what this changed as far as nurse practitioner scope of practice. And the scope of practice is that still within the realm of nursing. And it does allow for some practice to take place in the medical room as well that happened before with the use of standardized procedures. That practice is maintained, and that is a practice that California has experienced for many, many years with no adverse effect. And so what this does at that point is simply remove that standardized procedure supervision. Now, it doesn't remove all supervision, and that I think is clear that needed to be summed up in the comment period as well, is that the nurse practitioner that graduates from school has to work under standardized procedure and has to work under the supervision of a physician surgeon for the time that they're working on their transition to practice. Then if they progress to the 103 NP that is commonly referred to, they no longer have to work under standardized procedures, but they do still have to work within a healthcare facility. They do still have to work within a group setting that has, at minimum, one physician or surgeon in that practice with them. So that does not give them the carte blanche that I think some of the people were fearful of. And then when they complete 3 years in that healthcare setting, in that group setting with a physician or surgeon, only then can they advance to the 104 section. We will not see the 104 NP come to fruition until probably January of 2026. If again, everything goes through with the regulatory package, and it is of course dependent on whether or not we can implement in January of 2023, because you have to be a 103 NP for 3 years before you can become a 104 NP. And so when you become a 104 NP, after 2026, you will see nurse practitioners that can work in a more independent fashion. They will not have to be within a group setting, and they will still have to practice within their national certification, and they will still have to have transfer agreements and processes in place for consultation, etc. So they are not in a position that expands their scope of practice more so, but more so gives them less supervision as they progress through that pathway. And so that was one of the biggest things that we saw stand out around whether or not a lot of nurse practitioners would then be able to perform surgery. And that is still not something that is supported within our Nurse Practice Act.
Thanks, Lori. That's very helpful.
Thank you.
And then if I might add on to EO Melby's comments, there were a number of comments where people wanted things changed, but really what they wanted changed was the statute. There was a lot of areas where you know, they, for instance, just the naming and the Spanish naming, we are locked in by the statute on a number of things that we can or can't do at this point. And so that was a number of comments that, you know, at this point we can't change. And then in terms of the transition to practice, we obviously are on the right spot because, you know, if we have our number of years, there were a number of people that wanted absolutely no time. And there was a lot of comments that wanted 5 or 7 years. So we're kind of, you know, in the middle of between 0 and 7 is where we're falling. And so, you know, you can't please all of the people all of the time. And sometimes when no one's perfectly happy, that's when you've got your good middle ground balance.
And one of the comments that you'll see stand out that was made by the board is it says, as to statutory changes, the board is only authorized to regulate based upon current statutory language. The board does not have the authority to change or amend current statutes through the rulemaking process. And you'll see that on several comment responses. And those are the ones that will lead you to understand that they're asking for something that we don't have the authority to grant. That would have to happen through a introduction of a bill and passing through a legislative session in order to give the board the authority to grant them the change that they're requesting. So it may not be that that comment was not appreciated, that comment was absolutely appreciated, and maybe something that the board might take into consideration in the future, but it's not something that we can do at this moment because we don't have the statutory authority to do it.
I have a comment. I did read through all of your responses as well as Tricia, and I want to thank you for the clarity and the context with the business codes and the regulations, that how you explained why things are the way they are. So this was not only a tutorial in healthcare for me, but also a tutorial in how to respond to comments. So thank you so much for how you put your responses together. This was very well done.
Thank you. That was a team effort too, and I'd like to give a shout out to Marissa Clark and Heather Hoganson. It was through their assistance, through some sleepless nights and some long weekends, that we were able to get this done. This is something that it was very involved, and I'm just really happy with the direction we got from DCA. DCA opened it up when this first passed and said, have stakeholder meetings before you even start the regulatory language. And we did. And we held several stakeholder meetings. We really encouraged the public comment and the interaction so that we kind of knew what we were up against, and really kind of whether or not it had to be addressed in regulation or whether it had to be addressed with getting some further statutory authority. And so it was really, really helpful with that. So just really kudos to the team to get this going.
Any other questions or comments from the board? All right, I would like to make a motion. And the motion is to approve the proposed responses to public comments with any edits as discussed today.
So there were no edits, so we would not have edits. Is that correct?
Yes.
Thank you.
Direct staff to take all steps necessary to complete the rulemaking process. Authorize the executive officer to make any technical or non-substantive changes to the proposed regulation, and adopt the proposed regulation either as described in the proposed text or with the amendments discussed today. So we're going to adopt within the proposed text.
So I'll clarify the motion just because it gave you several options, Dolores. And
Yeah.
so it would be motion to approve the proposed responses to public comment and direct staff to take all steps necessary to complete the rulemaking process, authorize the executive officer to make any technical or non-substantive changes to the proposed regulation, and adopt the proposed regulation. If no, I think that's it, just adopting it. Yeah. Since we wouldn't be doing any change and going back out to a public comment period.
Right,
So that was-
as noticed.
Thank you, as noticed. Thank you.
I'll second that motion.
Thank you. All right, BRN moderator, can we open it up for public comment?
We will be opening for public comment now. I will be activating the question and answer feature. Please refer to the screen share for members of the public to see how they should type in their request for a comment. I've activated the question and answer feature. Members of the public can indicate they would like to make a comment by typing into the question box, "I would like to make a comment." Please remember, you will have 2 minutes to make your comments. I will not give a reminder as your time approaches. I do not want to interrupt you nor cause you to lose your train of thought. I will mute your microphone and inform you that your time has expired, and we'll move on to the next member of the public. I'll pause for a moment for members of the public to type in, "I would like to make a comment." Please submit that you would like to make a comment one time. There are many requests here. We will get to you one right after another. Dr. Stephanie Dittmer would like to be first. 1 second, please.
Yes, thank you very much. With regards to some of the recommendations on this regulation that's being proposed in motion for approval, I would like to very quickly call out that the recommendations by the MPAC to allow for grandfathering in of nurse practitioners with their clinical experience prior to January 1st, 2023 is outside of the statute, that there was no independent or outside of standardized procedure care prior to that. So to include any sort of clinical care prior to that is outside of the statute. I also want to voice my opinion that outside of the MPAC recommendations to allow for the doctor of nurse practitioner clinical roles to include in their hours towards their experience for the 103s should not be allowed. Those again were not under supervised care. They were not outside the standardized practice, and over half of most DNP practices is not clinical in nature. That additional 1 year of time is not the equivalent of what I think the statute was trying to get at. I also wanted to voice my very clear opinion that the physician care and referral requirement that is currently in statute is not being adequately addressed by the recommendations. Right now, it's discriminatory towards our marginalized populations, especially migrants and undocumented patients, as well as people who do not have English as a primary language. To expect for them to voice concern that they need additional care or they need to be referred out or they need additional physician level care places the onus on them as opposed to the actual clinician that they're seeing. I also wanted to very clearly say that the subject matter experts of nurse practitioners is not the same as MDs and DOs. And in the process of the OP requirements that were stated that no additional certification process outside the national exam is insufficient. And in fact, it said the additional standardized criteria for clinical training and mentorship should be included in the NP transition to practice requirements. And that has not been accommodated for in the current recommendations. I'm very much concerned that the safety of the patients in California do not understand what we're doing here and that we have not put adequate safeguards. The mental health nurse practitioner 1 year role of additional training as one of the specialties is not adequate for being able to provide the same level of outside of standardized procedure care. The 600 hours versus the 17,000 hours is not the same. And I don't think that there's adequate safeguards that have been put into place. And so everything that we've done up to this point.
Thank you for your comment. Your time, allotted time is expired. Sorry.
This is Reza. Can we keep Dr. Dittmer on for just a sec? I wanted to try to get some clarification on one piece of that. I'm not sure if I correctly caught it. I think one of the early portions of your comment, Dr. Dittmer, you said that the grandfathering in of clinical experience prior to January shouldn't be counted because it's outside of it's not consistent with the statute. I'm not sure if this is relevant to what you were commenting or if I'm confused about what you were saying, but section 2837.101C allows clinical experience. It says may include experience obtained before January 1, 2021 if the experience meets the requirements established by the board. So it's in statute that prior experience can count towards the transition to practice, or were you speaking of something else?
No, I'm saying that the requirements that are listed in statute of that experience prior to January 1st, 2023, those specific requirements that are stated do not allow for adequate supervision of care to fit the requirements that the intended purpose of the bill was meant to safeguard. Up until now, when this goes forward, we will have the adequate supervision and components of mentorship because it is now expected as part of that process for nurse practitioners that desire to become 103s and 104s. Up until this point, that was not the level of care, and it was not the expectation that the level of supervision and training that's going to be needed to be done outside the standardized practice. So I do not believe that the work that's been done this point adequately meets the spirit and the statute.
So I'm understanding that prior experience gained would not have been under the kind of new paradigm of practicing outside of standardized procedures, but obviously the legislature contemplated that and specifically stated that experience prior to January 1, 2021 could be used. That's my understanding anyways, that to me, if we're on the same page, it doesn't appear to be outside of the statute, though I understand your concerns about the experience being of somewhat of a different nature. So thank you.
I think one clarification I could possibly provide, Reza, is that the experience that's being taken into consideration is experience done under standardized procedures. And that is what is required to date with the traditional NP and for the transition to practice. That transition to practice to the 103 NP must be done under standardized procedures with the physician surgeon. And that is the same requirement that we have right now for anybody practicing as an NP. The 103 to the 104, that is done without standardized procedures, and that cannot take place until they become a 103 by completing the transition to practice. So that's not something that was necessarily shortened. There was consideration taken in by the NPAC that might be what this Commodore is talking about. And that is where they looked at any additional clinical time that was done during the education period for the DNP that is in excess of what a master's prepared NP would have. And what they decided to do as the NPAC is do a direct hour-to-hour conversion for that. So if they said that they had 20 hours more than a master's prepared NP in that specific clinical focus, that could be counted towards the 103 to 104 section. And they didn't shorten it down to 1 year as some stakeholders had asked for. They didn't shorten it to 2 years as some stakeholders had asked for. They left it on an hour conversion because in the evidence that Dr. Kevin Maxwell, nurse practitioner on the Nurse Practitioner Advisory Committee that was on that subcommittee brought forward was that there was not a lot of extra clinical practice in a specific specialty done as part of the preparation for the DNP. And so it wasn't supported in evidence to decrease it down to a 1 year or a 2 year stint as a 103 NP moving to a 104 NP.
Thanks, Lori.
Thank you. Adrian Shelton would like to make a comment. 1 second, please.
My name is Adrian Shelton, and I represent the California Alliance Child and Family Services. We are a statewide organization that represents nonprofit community-based agencies serving children and youth and families in public human services systems, including behavioral health. We were a strong supporter of AB 890, and we have long been supportive of nurse practitioners practicing independently, as many of our providers utilize teams of physicians, nurse practitioners, and other healthcare professionals to provide behavioral health care to vulnerable children and families. All of our member organizations know how difficult it is to recruit and retain behavioral health care providers, which is why we should be increasing access quickly to as many of these professionals as possible. We urge the board to adopt the current regulations to close our state's growing provider gap. Thank you for the opportunity to provide feedback today.
Thank you for your comment. Wendy Wang would like to make a comment. 1 second, please.
Afternoon. My name is Wendy Wang, and I represent Sycamores, a nonprofit organization that provides mental health and child welfare programs in Southern California. Sycamores strongly endorsed Assembly Bill 890 when it was debated by the legislature, and we appreciate all the efforts taken by this board to implement this crucial bill. Sycamores largely serves adults who have a severe mental illness and children with severe emotional disturbance who are eligible for the Medi-Cal program. The public mental health system has been significantly impacted by California's healthcare provider shortage, which was exacerbated due to COVID-19 and the increasingly tightening labor market. Nurse practitioners are crucial to help relieve the pressure on our public mental health system and the entire healthcare system. They are qualified, highly educated individuals who are well positioned to address gaps in care. Therefore, we support the BRN's proposed motion today to move forward with the adoption of the current regs with non-substantive changes so that NPs can begin to increase access to care as envisioned by AB 890. Thank you.
Thank you for your comment. Denise Cuevas Romero would like to make a comment. 1 second, please.
Hi, good afternoon. Dennis Cuevas Romero, Vice President of Government Affairs at the California Primary Care Association. The PCA represents more than 1,300 not-for-profit community health centers and regional clinic associations who provide comprehensive quality healthcare services, particularly for low-income, uninsured, and underserved Californians who may not otherwise have access to care. CPCA supported AB 890 when it was in the legislature, and we appreciate the work that the BRN has undertaken over the last 2 years to fully implement AB 890. We support the regulations developed to allow nurse practitioners to work to the full extent of their education and training, expand access to care, and begin to practice as intended by AB 890. CPCA remains ready to serve as partners to the Board of Registered Nursing and stakeholders on the implementation of these regulations in community health centers. Thank you.
Thank you for your comment. Sarani Harkwan would like to make a comment. 1 second, please.
You to Chair Trujillo for this topic. I want to urge the BRN to move forward and adopt these regulations as quickly as possible. I am a nurse practitioner that works in a very rural part of Northern California, and I serve a number of underserved populations, including many homeless and farm workers. I do serve my patients in Spanish. They are well aware that I'm a nurse practitioner, not a physician. I'm very proud of the fact that they can speak to that when asked. And they come back and see me year after year. I've been with this particular clinic for 22 years and delighted to be taking care of the second generation of farm workers in that community. I want to thank EO Melby for all of her support in this particular regulation. And I also want to thank Chairperson Samantha Gambles-Farr for all of her work. I echo your sentiments in the journey that we've been on for the past year and a half. So with all of that said, I'd like to remind the board that this bill will increase access not change what nurse practitioners actually do. EO Melba, you said it exactly right. I am not going to be some different person when these regulations are adopted. I will continue the same high level care that I provide to my patients every single day, and looking forward to having this implemented. Thank you so much.
Thank you for your comment. Ron Ordona would like to make a comment. 1 second, please.
Good afternoon, everyone. My name is Ron Ordona. I'm a nurse practitioner in a group setting called Senior Care Clinic House Calls. We strongly supported AB 890 when it was in the legislature and appreciate the work that the board has done so far in implementing this important bill. At Senior Care Clinic House Calls, we serve the homebound elderly population in the Sacramento region, going up to the foothills and sometimes driving an hour to get to them. They are impacted severely by California's healthcare coverage and shortage. Nurse practitioners, as studies have shown, are alleviating the pressure in the healthcare system. Nurse practitioners are driving the force in growing home-based primary care or doing house calls. We urge the Board of Nursing to adopt the current regulations so that nurse practitioners like myself and others in our practice can begin to expand access to care, especially those that really, really need it, as was intended by AB 890. Thank you very much.
Thank you for your comment. Mary would like to make a comment. 1 second, please.
Can you hear me?
Yes, we can. Thank you.
Thank you so much. Good afternoon. My name is Dr. Mary Tahiri and proud nurse practitioner for 17 years. I work for DHS, LA County in Skid Row, downtown Los Angeles, with patients experiencing or previously experienced homelessness. I'm a member of SEIU and Nurse Alliance Committee member. We strongly support AB 890 and appreciate the work that this board has done so far in implementing this bill. I left the private sector 15 years ago to come work for DHS LA County, helping the underserved, the uninsured, the veterans, people experiencing homelessness, and the undocumented. I have noticed over the years that the wait for our emergency rooms in the county facilities in LA has not improved. It's gotten worse, over 12 to 24-hour wait. Patients utilizing emergency rooms for medication refills or healthcare issues that can be seen by primary care providers, but because of the lack of PCP providers or longer than 1 month wait to make these appointments with their PCPs, it has had a domino effect on our entire healthcare system. Every day that AB 890 is delayed, this likely has an effect on patients' health and well-being, specifically in our underserved communities, due to lack of PCP and preventive healthcare. So please, I ask and urge the board to help AB 890 move forward as planned by January 2023. Thank you so much for your time.
Thank you for your comment. Sharon Bogan would like to make a comment. 1 second, please.
Hello?
Go ahead.
Oh, okay, sorry. Yes, thank you. I would like to first thank and give a shout out of appreciation to the Nurse Practitioner Advisory Committee and the Board of Registered Nursing and all people making public comments. My appreciation goes out to people on both sides of the issue. Having both perspectives voiced ensures that we are looking at all aspects of an issue. I have always listened, and especially to those who adamantly oppose my personal views, because I'm always listening for something I haven't yet thought of or appreciated enough. This is an absolute must when we are talking about quality healthcare. It also demonstrates how much all of us care about the people in our communities, since the main focus and purpose of the passage of AB 890 is first and foremost about the health equity, and the quality of care that's being delivered to all people. I understand the seriousness and gravity of scope of practice of any profession, and I want to ensure the members of the board and public members listening that nurse practitioners are educated and trained to care for people within our professional and individual scope of practice and experience. None of us would even think of practicing outside of what we are educated and trained to do. That would not be good for the patient, and we understand that. I also teach, and it has been my mission to ensure that students who are graduating understand the responsibility they and have to appreciate and honor the role that nurse practitioners have to work with our healthcare colleagues to provide quality care.
Thank you for your comment. Margaret Parsons would like to make a comment. 1 second, please.
Impact and the board on drafting regulations. I'm a physician in Sacramento. I work with an advanced practice clinician as well as leadership and organizations in the Sacramento area, and the importance of what APCs, as nurse practitioners and others can provide to expand care. I think it is important part of the healthcare team. I do feel that the OPES language that talks about additional clinical experience and mentorships as part of transition to practices is an area that the regulation could have further explanation. As a physician, we go through training where we have school, internship, residency, board tests, practice board tests, board certifications, many levels of testing. While the OPS has chosen not to recommend a supplemental exam, they do recommend that additional mentorship. I think it's important that the board consider adding language that the mentorship include those that have been doing that higher level of care, management of a clinical panel of patients, and that it's a little difficult for mentorship unless you have that physician level of supervision for part of the training or all of the training, but at least part of it. And at this point, because there aren't 104s that manage independent panels of patients, it really is that higher level of someone who's done that. I would like to see that the language regarding mentorship be amended to include the experience at a higher level than what is being applied for. I think that that could be very helpful to guarantee the safety, that we make sure we have that extra training and mentorship. And in medicine, we all enjoy our mentorship. It's part of what we learn from in those conversations where it helps us grow and be better clinicians. I think there's room for amendment there. I appreciate the comments about notification and just supporting the comments, and not just that the written and verbal notifications, but that it truly be something that people from varying levels of education, understanding of the healthcare system, and languages can understand what is going on with their healthcare. I think that's important when we describe who is providing their care, what care they're able to have for all of us, and to make sure that we recognize so many people.
Thank you. Your allotted time has expired. Rudy Posadas would like to make a comment. 1 second, please.
Mi nombre es Rudy Posadas, secretario de la Unión de Guatemaltecos Emigrantes. Quisiera agradecer al personal de BRN por tomarse el tiempo de reunirse con algunos grupos comunitarios para escuchar nuestras sugerencias para las regulaciones. Muchas de nuestras preocupaciones no se abordaron después de que enviamos cartas de comentarios y participamos en audiencias públicas para expresar nuestras sugerencias. Nuestras solicitudes son para garantizar que el público, especialmente las comunidades de habla hispana de bajos recursos, entiendan la diferencia entre una enfermera especializada y un médico. Los pacientes deben ser informados para que conozcan las circunstancias en las que deben acudir a un médico. Durante una emergencia médica grave, un paciente no debe llamar a una enfermera especializada. Las regulaciones no garantizan que los pacientes estén protegidos. El BRN debe tener un proceso para incluir a los grupos comunitarios al desarrollar regulaciones en el futuro. Los grupos comunitarios pueden proporcionar información valiosa para garantizar que el público realmente esté informado y sepa acerca de los diferentes proveedores de atención médica. A medida que BRN desarrolle regulaciones futuras, continuaremos participando y brindando comentarios para garantizar que el público esté protegido. Muchas gracias.
Thank you for your comment.
Thank you. Before we go into the next public comment, I want to remind the board members that on the WebEx, down on the bottom left of your screen, you will see a closed caption kind of bubble there. If you click on that, you can have it do a translation for you from Spanish to English, so that you can understand any future public comment if you were not able to understand that one that was just here. Thank you.
Karen Sonnenthal would like to make a comment. 1 second, please.
I'd like to comment on a couple of things. First of all, I strongly disagree with Stephanie Dittmar. Her comment regarding the previous supervision was not adequate to advance an NP to practicing without the standardized procedures and move on to a more independent practice. As an NP here in California for over 25 years and a current partner, board member, and director of the NPs at John Muir Medical Group, I have firsthand witnessed the onboarding supervision of new NPs, both new graduates and new hires that have extensive experience in primary care. They are still work very closely in the clinics with the team that they are collaborating with, and with the goal that that level of supervision would diminish as core competency and clinical competency is confirmed. I also want to strongly encourage passage of the bill to allow 103 NPs to start working in as soon as possible. It is very difficult in our medical group to even hire new NPs into some of the offices in our more remote areas, simply because the physicians in those offices do not want the supervisory responsibility. If we could, they have no problem working with an NP. They just don't necessarily want to be, tagged onto as that legal responsibility. The 103 NP would be able to move into that clinic, increase access in these very overtaxed clinics, reduce the burden of the urgent cares and the ERs in the area, and really just enhance access for primary care. So I thank you to the committee for looking into all of this and would really support passage of the bill as stated. Thank you.
Thank you for your comment. Laurel Malia Ruffsetter would like to make a comment. 1 second, please.
I work at a high school health center for a low-income, underserved population. And I want to thank the BRN for their leadership and the advisory committee, because I think it's really important to adopt the regulations ASAP so that we can expand care, and that was what was intended by AB 890. I also wanted to state that I think that we will be able to help a lot more patients, and it will be very beneficial for this to go forward. Thank you so much. I appreciate you taking my comment. And thanks again for all this important work.
Thank you for your comment. It says Dr. Cynthia Yovanov, but I don't see her in the... She's disappeared. Sorry. Kathy Hughes would like to make a comment. 1 second, please.
Hi, this is Kathy Hughes. I'm a registered nurse and the executive director of SEIU Nurse Alliance of California. As part of a coalition that includes the California Association for Nurse Practitioners, the California Hospital Association, and SEIU, we urge the board to move the process forward and adopt the regulations quickly. Nurse practitioners are key to alleviating the pressure on our healthcare system. They are qualified, highly educated professionals who are ready to provide the complex care needed for a diverse population of California and close the provider gap. We'd also like to take a moment to express our appreciation to the BRN for their tremendous work and our opportunity to participate in the process. We urge the board to adopt the regs. Our patients can't wait. Thank you very much.
Thank you for your comment. Dr. Cynthia Yovanov would like to make a comment. 1 second, please. Dr. Yovanov? You're unmuted. Go ahead.
Thank the NPAC committee as well for doing their hard work because this has been a long road. In review of all the comments, that was 55 pages long. It looks like majority of the, well, probably all of the recommendations were denied. However, what I do appreciate is the detail into the rationale of why it was denied. I will add that maybe a small consideration in regards to the regulations is to consider from a 5-year to a 7-year recognition. And the only reason why this was recommended was to really give credit to our educators and to those who have been on medical leave and to really extend that time for them, which would increase the pool of nurse practitioners moving forward to a 103 and 104. In previous data that was extracted in regards to the nurse practitioners that we currently have, close to 33,000, in previous data, moving a nurse practitioner from standardized procedures to a 103 would essentially create close to 20,000 nurse practitioners eligible. And for this is phenomenal because it would allow us to move into the communities that need care. In regards to some previous comments about needing more mentorship and collaboration, many of us, as just stated, 20,000 of us NPs are already practicing closely with physician colleagues. And so the mentorship is there. Many of us work in really high level institutions and we're providing a lot of support to even our new residents. And so I think, some of this is really unrecognized of some of the nurse practitioners that are currently doing the work side by side with many of our colleagues. We look at all our physician colleagues, health care colleagues as team members and really not to be in opposition here. And so I really want to thank everybody on both sides, those that are on opposition, because we do value some of your comments. However, it's not always beneficial to the communities that we're serving. We're all here to serve the same purpose for everyone, for our patients, for our communities. And again, thank you for moving these regulations.
Thank you for your comment. Your allotted time has expired. Katrina Reyes would like to make a comment.
Hold on.
Yes, yes.
BRN moderator, we've been taking public comment now for just about 30 minutes. I would like to ask the board if they would like to continue to take comment for probably another limit of 30 minutes. That will make an hour for public comments. Are there any questions or comments regarding that from the board?
My only comment is that once the public comment period ends, could we do a lunch break? My staff are reaching out to me.
Sure, no problem with that.
Thank you. Board moderator, how many more public commenters do we have in the queue?
15.
So 15 at 2 minutes each will put us at 30 minutes. I think that's appropriate. Thank you. Back up.
All right, so we'll do public comment for another 30 minutes. Sorry to interrupt. Thank you.
Thank you. Katrina Reyes.
Reyes with the California Academy of Family Physicians. We urge the board to consider whether the necessary measures have been put in place to ensure that NPs have the training, experience, and competency to perform the functions specified in the law without standardized procedures. The legislature gave the BRN express rulemaking authority to implement AB 890 and to do so with the BRN's mission as a guiding principle to protect California's healthcare consumers. The OPAS report recommends that rather than a supplemental examination, additional standardized criteria for clinical training and mentorship should be included in the NP transition to practice requirements. It further states that while core competencies can be assessed with an examination, more complex competencies like clinical decision-making may be better assessed through additional training and mentorship, may be assessed through on-the-job supervised clinical experience and mentoring programs. Yet standardized criteria for additional clinical training and mentorship are not addressed in the proposed regulations, nor is how complex competencies such as clinical decision-making are to be assessed. We are concerned that the proposed regulations have left minimum standards for transition to practice largely undefined with no standardized criteria. Thank you.
Thank you for your comment. Marco Lizarraga would like to make a comment. 1 second, please.
Board moderator, he has asked for his comment to be read as he cannot make a statement anymore since he lost reception.
Okay, I was gonna try him, and if he didn't reply, then I was gonna ask for that.
Yes.
Marco, are you able to make your comment?
I can read it.
Okay, thank you.
Okay. This is from Marco Lizarraga with Law Cooperative Compensating for De California. I cannot provide my comment verbally because of bad reception. I request that it please read the following comment to the public. I would like to thank the BRN staff for taking the time to meet with some community groups to listen to our concerns. However, many of our concerns were not addressed after we submitted numerous comment letters and participated in public hearings to express our concerns. Our requests are to ensure that the public, specifically low-income Spanish-speaking communities, understand the difference between a nurse practitioner and a medical doctor. Patients must be informed so that they know the circumstances when they must see a medical doctor. During a serious medical emergency, a patient should not be calling a nurse practitioner. The regulations fall short to ensure patients are protected. The BRN should have a process to include community groups when developing regulations. The community groups can provide valuable information to ensure that the public actually is aware and knows the different healthcare providers. As the BRN develops future regulations, we will continue to engage and provide feedback to ensure the public is protected. The BRN should do better to engage the public and not just make some posting on social media asking for feedback. Thank you.
Thank you for your comment. Sarah Bridge would like to make a comment.
Thank you. Sarah Burge on behalf of the Association of California Healthcare Districts. We represent the 77 healthcare districts throughout the state of California who service the state's most vulnerable and underserved patient populations. I want to first thank the BRN for the work on implementing this important bill thus far. Nurse practitioners are key to alleviating the pressure on our healthcare system. The intent of AB 890 was to allow these highly trained, experienced, and qualified nurse practitioners to expand access to critically needed care throughout California. California, at the adoption of these regulations, will have the most robust transition to practice requirements in the country. Adding unnecessary transition to practice requirements, including discounting prior clinical experience, are not consistent with the intent of the bill and will further delay a nurse practitioner's ability to expand access to care. We urge this board to adopt the current regulations so the nurse practitioners can begin to expand access throughout California for our most vulnerable patients, as was intended by AB 890. Thank you.
Thank you for your comment. Charlotte Sui would like to make a comment. 1 second, please.
Afternoon. My name is Charlotte Sui, and I'm speaking on behalf of the California Medical Association. We represent nearly 50,000 physicians who value nurse practitioners as a critical member of the healthcare team. I also want to thank the BRN for the time and labor it has put in towards AB 890. We do believe that this regulatory package deserves additional attention because of the significant implications it would have. In particular, we're deeply concerned with the proposed language around transition to practice, as many have already pointed out. The current draft lacks substantive guidance on the transition to practice requirements. If you take a look at the current draft, it contains many logistical outlines of what the application process should look like, but little to do with the content of the training, which is necessary for quality standardization. We ask that the BRN include language that would create more formal requirements for clinical training and mentorship. And we recommend, for example, that mentorship take place in a structured environment, which would benefit both nurse practitioners and patients alike. We do support the creation of a mentorship subcommittee, and while that has been discussed for a later regulatory package, we believe it would benefit, this current package would benefit from adding that to this process now. On the consumer protection front, we additionally ask that the BRN explicitly state within regulations what BR 103 and 104 NP cannot do. The current scope statutory language defines what nurse practitioners can do with standardized procedures, but it's less clear on what these new categories of nurse practitioners can do independently. And this therefore creates a dangerous precedent where scope is inconsistently being defined across the state from facility to facility and from NP to NP on what a 103 and 104 can do, NP can do, to the detriment of patient safety. Thank you.
Thank you for your comment. Alejandro Salis would like to make a comment. 1 second, please.
Good afternoon, Alejandro Solis on behalf of community groups, Los Amigos de la Comunidad, Coalición de Buena Salud y Bienestar, Comité Cívico del Valle, and Communities for New California. Our primary concerns with the proposed regulations is that the BRN moved very fast while disregarding the underserved low-income Spanish-speaking communities we represent. We had to continuously submit letters and provide public comments in order to get a meeting with staff. Our concerns were not addressed other than to advise us to introduce legislation or make amendments. We request that BRN staff in the future convene stakeholder meetings, as our requests were not responded to until we continue to engage after submitting numerous letters and providing public comment at every meeting. Our letters have requested the regulations to include the following. A, safeguards must be put in place to protect patients, as there will be confusion among low-income communities who may think that they are receiving care from a medical doctor when in fact they are not. We have been requesting the following: the right for patients to be informed in writing that they are not receiving care from a physician and that they have the right to see a physician. Patients should have a right to receive this information from a nurse practitioner without request. Placing such disclosure requirements on the nurse practitioner will ensure that all patients, and especially those in low-income communities, receive critical information about their care. Nurse practitioners must have adequate education and training that will give confidence to communities and ensure patients receive safe, high-quality care. Nurse practitioners must be adequately tested to ensure that their competency is sufficient to provide quality patient care in any setting in which they are allowed to practice and to ensure that they are keeping up with their education. We look forward to engaging with the BRN for any future regulations that are proposed for AB 890. Thanks again for the opportunity to provide comments.
Thank you for your comment. Leslie Bloomquist would like to make a comment. 1 second, please.
Hi, my name is Leslie Bloomquist, and I've been a nurse practitioner for 26 years. I'm a member of the California Association for Nurse Practitioners Kern Tulare chapter. I want to thank the board for all your work to expand and increase access to healthcare for all Californians. I support the motion to move forward and adopt this regulation as soon as possible. Thank you for your time.
Thank you for your comment. Margaret Johnston would like to make a comment. 1 second, please.
Margaret Johnson. I've previously introduced myself. I again would like to commend the board for the work they've done in advancing this bill and making improved health care possible for all Californians of diverse languages and cultures. My comment will be confined to the importance of opening access to care, not truncating it. This should be about providing safe, competent care. Research after research tract has proven that NPs offer safe, competent, as well as high quality care. All primary care physicians and providers really act the same way. We understand our scope of practice. We refer to higher level care to specialists as appropriate. So that's really not the issue because we have the same knowledge base in terms of knowing what's an emergency and what we can't take care of. So I think the overriding issue is to provide care for more people. I'd like to share an example with you. I work in the county system, DHS and LA County, and I recently had a patient who told me that I diagnosed him with multiple myeloma, and he'd waited 2 months to get into the county clinic because the clinic was closed because of lack of providers. And also he had to get a hold of a Spanish speaking provider, which added to the delay. So due to panel closures, facility closures to new patients, our patients are experiencing what could be a lethal delay in care. In his case, it was. I don't want to see that happen again. So again, I urge the board to go ahead and not add any more practice requirements. Thank you.
Thank you for your comment. Rebecca Goldfader would like to make a comment. 1 second, please. Rebecca, go ahead.
Hi, my name is Rebecca Goldfader. I am a women's healthcare nurse practitioner for over 30 years in practice. My specialty includes LGBT health, as well as hereditary breast and ovarian cancer and breast health. I am speaking with you today based on my 30 years of experience to truly urge the board, the BRN, to move the process forward and adopt these regulations quickly so that nurse practitioners can begin to expand access to care as soon as possible. We've seen in states across the United States that California is lagging behind, and it is time to support the passage of this bill and allow such highly trained nurse practitioners with decades of experience to practice at the level of their scope and expertise. Thank you.
Thank you for your comment. Board President Trujillo, Alyssa Brown is the last one. 1 second, please.
Hi, good afternoon now. Last but not least, right? Thank you. My name is Alyssa Brown. I am a clinical nurse specialist, one of the 4 APRN roles. I believe that all providers must identify who they are and what they are, regardless of what their profession is, to their patients. So I don't think that is an issue here. I support moving ahead with these regulations in the interest of providing increased access to healthcare to the public by qualified providers, and in helping our BRN to complete reviewing, updating, and creating needed regulations. I hope that the concerns that have been voiced will continue to be heard and responded to. I thank you, and again, I urge that you move ahead.
Thank you for your comment. Board President Trujillo, there are no other public requests for comment. Would you like me to close this window?
Yes, please.
Board President, I'd like to take a second really quick
Sure.
So most of the comments that were brought up in this public comment period have been addressed in that packet that the board has received and reviewed, but I do want to take a minute to offer up any additional clarification that the board members may have in regards to any of the public comment that maybe they felt was not adequately addressed in that packet, or if they were, or if it was missed or unable to be found. Great, thank you.
All right.
Or-
Go ahead.
I was just letting you know that since there was no other comments, you can take it to a vote.
Yeah, thank you. So we have a motion and a second on the floor. We'll take it to a vote. Dolores Trujillo votes yes. Vice President Mary Fagan.
Mary Fagan, yes.
Elizabeth Woods.
Woods, yes.
Jovita Domingos.
Jovita Dominguez, yes.
Thank you. Patricia Nguyen.
Tricia Nguyen, yes.
David Lawler.
David Lawler, yes.
Susan Naranjo.
Susan Naranjo, yes.
And Vicki Granowitz.
Vicki Granowitz, yes.
Thank you. At this time, we could probably break for lunch.
That sounds good. Appreciate it.
Be 5 minutes or an hour?
Do you want to just aim to be back at 2 o'clock? That is 42 minutes. So, or do you can go ahead and lengthen it as well. We've been going for quite a while. If you want to do to 2:30.
About an hour, 2:15, approximately an hour, give or take a few minutes.
Give or take a few minutes. We'll do that. We'll be back on at 2:15 and we will start with agenda item 6.2.
Correct. All right, everyone have a great lunch and see you back here at 2:15.